Okay, I think we're actually all going here. So
There you go, Jim.
looks like I'm back to being host. All right, well, let's get ahead and start the seminar. You guys all ready?
Ready?
Ready.
All right, here we go. Well, good afternoon, I guess it is. It's right afternoon. Just wanted to touch base and tell everybody I'm very excited. Life's Co-Pilot, we have a great panel here today. We're talking about a topic that most people try to avoid. They don't want to talk about it because they don't understand it. They don't know what it means. They think well, this is the worst part. They think they know what it means, but they're wrong in 99% of the cases. I know myself, I had no idea what it was all about until I got to meet a lot of these folks and learn a whole lot more. And my own family would have benefited tremendously had I had this knowledge previously as opposed to after the fact. So I'm going to just go ahead and we're going to talk about hospice today. I think it's the most misunderstood word in all of healthcare and our care to our loved ones. So I'm just going to go ahead and have all you guys introduce yourselves and take your time. Introduce yourself, tell me who you are, tell me who your company is, tell me what you do, what areas you cover, and maybe why you got into this in the first place or how you found yourself into this. So I'll just let you kind of go through that and then we'll go from there. And I'm going to make a confession. I now take these videos and I cut them up into smaller segments. And by having you take your time to do that makes it so much easier for me later to do. So anyway, I have method to my madness. So Cheryl, you're the first one I see on my screen here. So I'll let you start.
Well, hello, everyone. My name is Cheryl Molnar. I have worked for Guardian Angel Hospice for a total of about 7.5 years. I was a school teacher and owned a Montessori preschool daycare for about 20 years. And then my mom got sick, and actually today is her birthday. She would have been 76 years old. And so I do this in honor of her every day. Hospice was a God-changing thing for me. They helped my family. I'm the oldest of 4 in so many ways, and took such a huge weight off of our shoulders, helped with some family dynamic issues. And that hospice nurse that I had met just a couple weeks before became truly somebody that I trusted with my whole heart. So I knew it was a God calling for me, and I've had to find a way to get into it. So I actually marketed for a non-medical home care company is how I got my start. And because I had a teaching degree, so I wasn't really sure how to get into it that way, but and been going strong, and just it's not work as far as I'm concerned. I love what I do every day. It's a ministry. It is important work that we all do. And we just turned 20 years. We just hit our 20th year anniversary. So we're really proud of that. A lot of the other companies, the privately owned companies, have been bought out, but we stand, I'm pretty sure, one of the last ones left with that longevity. So I think that means a lot out there. We do what we say we're going to do, and ethics is very important to us.
Very good. Well, thank you. Madison, tell us who you are and what you guys do a lot of stuff. So
We do, yeah. So my name is Madison Gonzalez. I'm the executive director at Morning Light. Morning Light runs the award-winning Abby Hunt Bryce home. We're here in Indianapolis, the only free residential hospice home of our size and scope in the entire Midwest. So we are a 12-bedroom facility. We are a nonprofit, so we don't charge our residents a dime for staying with us. It's a completely free service that was founded about 18 years ago, and we work with local hospice agencies here in the city. We partner with, we don't have any exclusive contracts, so we partner with everyone and anyone, because the whole goal is to really eliminate any of those barriers that would keep an individual from receiving hospice care. And to receive the hospice benefit and to work with a hospice team, you need an address. And so we serve a very niche population here in the city. We serve people who don't have a suitable living environment. So it might be actual homeless situation where someone's on the street, or it might be a situation where their home is condemned, or there's a hoarding situation and the hospice teams just aren't comfortable going into it. The hospice agencies deserve a safe and clean place to treat and serve, the patients as well. And so that's what we provide. We're a 12-bedroom home here in the city. We work with a whole host of different agencies, hospitals, social workers, and we try to bring residents in. They stay with us for free, a warm bed, 3 home cooked meals a day, and then we partner with the hospice agencies for that medical oversight piece. So it's a very niche thing that we do. It's very unique, but we have served over 750 people since we've opened. So while it's very niche, it is very needed. And we're very proud to continue to partner with you all and serve the community.
We've worked with you. It's a wonderful place. I can't say enough about it.
Oh, that's so kind of you. Thank you.
Absolutely.
I'm glad you had a good experience.
Yes, we really did.
Lynn, tell me who you are and what you get. Well, I know that what you guys do because you're both here as a team. But go ahead, tell us all about you.
Yes, my name is Lynn Salem, and I am the Chief Business Development Officer here at Guardian Angel Hospice. We have been in business for 20 years, as Cheryl mentioned. I'm actually one of them who has been honored to ask to be a succession owner. So our original owners started our organization and are starting to retire. And so there have been 3 of us who have bought in to be able to continue the legacy of what's been started here. We actually cover 30 counties in North Central and Central Indiana. And as hospice, as Jim mentioned before, hospice is so misunderstood. There's so many myths that go with it. I started as a volunteer here 18 years ago. And so now I've worked in the admissions office. I worked as a marketer, and now I get to continue to go out and really help build my team to really spread the word about what hospice is, educate our communities, educate our referral partners, our physicians, our hospitals. As Madison alluded to, we meet them where they are. Anybody needs hospice. There are lots of people who are in need of hospice services, but they don't understand it and they don't know where to get it. Madison, thank you so much for having a place for people to go. And a lot of people misunderstand that hospice is a place. And it is an inpatient, hospice house, but we really meet them wherever their address is, whether that's in a card shop or a trailer or a camper or wherever that may be. It is definitely just us coming to them and meeting them on their terms. And we've been really very, very blessed to be able to serve so many individuals over the last 20 years. We are locally owned and operated, as Cheryl mentioned, and we're just going to continue to build on that legacy of bringing hospice services to anyone who needs it.
Excellent. Amanda, tell us who you are and all about you guys.
Yeah, so I am Amanda Quinn, and I am a hospice care consultant with Brighton Hospice. Brighton's actually been around for about 11 years now. They are based, our home office is out in Utah, and our company was actually founded by a nurse, and she was working for a company for quite a few years and just felt like, that company wasn't really serving their purpose. And she felt like her views were different from the hospice company she was working with. So she wanted to make sure that she served patients the way that she would want to be treated. So she branched off on her own, and herself and another one of our founders, who is also a marketer. And at the time, our founder, like I said, she was a nurse. So the two came together and created Brighton Hospice. And Brighton Hospice is a little different in that, we do put profits back into patient care, because no matter how we bill Medicare, at the end of the day, hospice companies and hospice providers, we're all reimbursed the same. So we wanted to make sure that our patients were seen 5 days a week. So we have from day one always scheduled our CNAs to see patients 5 days a week. And then we have nurses who go out to patients' homes 2 to 3 days a week, just for their regular visits and routine assessments. But we also provide spiritual care coordinators, social workers. We have music therapy, aromatherapies, and then of course your typical, if someone needs a respite, we can provide respite care, whether that's in a facility, or if somebody's diagnosis is their symptoms are beginning to get out of control due to their diagnosis, we can cover for them to go into an inpatient stay in the hospital so they can be comfortable and get those symptoms under control. But one thing I always like to talk about with our spiritual care coordinators, which are more formally known as chaplains. So our spiritual care coordinators actually go through a little bit of clinical training. And that is so that way they truly understand the death and the dying process for end of life. And that way, when they're out in the field speaking with families, they really know what they're talking about clinically, and they understand the end of life process and how to sit down with those families and those loved ones of our patients and explain, what they are going through as being a normal process during end of life. So it kind of gives us just a little bit more clinical expertise with our chaplain, and we feel, a little bit better support for patients out there, and not your typical chaplain. So that's why they are called spiritual care coordinators versus a chaplain, because we don't want people to just associate them with being a religious provider. They're much more than that. So, but Brighton is, we've been established here in Indianapolis for 3 years. So the company overall is 11 years old, but been here in Indianapolis 3 years, and we serve central Indiana. So that includes, of course, Marion County and most surrounding counties. We aren't quite up in northern Indiana yet, and we're not as far down south either yet, but we are growing every day and working on expanding our services. So that way, if there are people outside of our current territories, that we can continue to get to as many people as possible. So that's a big part of my job as a consultant, is to help educate about hospice, what we provide, the benefits of hospice. And then, of course, we, like so many other people have said, we serve patients wherever they call home.
Mhm.
Well, very good. We had one panelist that had an emergency taking care of a client today, and I don't want her left out of the mentioning here, but Lori Wallace with Life Journey Hospice, she also provides a building, for people can come to and be cared for. And the way I understand it, she has her own hospice, but she also, anybody else's hospice can come in there, working in there as well, just like with Madison. So these are some really good providers that offer things here in our marketplace that people may not be aware of. So, but like I said, she's taking care of a client, so that's more important than being here. So basically, I wanted to kind of touch base on this. We started this whole thing with the fact that nobody knows what hospice is. I think that's kind of where a lot of it begins. I know myself, my experience with hospice was, I think we thought, like a lot of people, that it's just a morphine drip in the last few days or what have you. When my father slipped into a coma, we had a doctor who came to the house, and then she called hospice, who showed up 5 minutes after Dad passed, which I was thrilled because she took care of the paperwork. But nonetheless, what I have learned since getting into this world is there's so much that my dad would have benefited from for months, if not longer. He had a terminal illness for at least 2 years. So there's an opportunity there that he could have had a great deal of benefit, and also taken a great deal of stress off my mom. So I had someone explain to me what hospice was that I thought was, I love the phrase that doctors teach, treat curative medicine. They're trying to fix something. They're trying to cure you. Well, if you're not going to be cured, if that is not a possibility, then that can be torture. Okay, really, as far as what it comes down to. And then, whereas hospice care is treating the symptoms rather than the cause, so you'll feel better. Maybe you feel better, maybe you eat better, maybe you sleep better, maybe you all of a sudden you actually get up and have a better quality of life.
Mhm.
That's my understanding that I learned. But please tell me what if you're sitting in a, you guys are getting out into the public, you're at somebody in your sphere starts asking you, well, what in the world is hospice, or what have you? Would you tell us so that we can start, getting people to understand what's out there for them? Cheryl, you're in my screen right now, so let you pick on this.
You're always picking me first.
Yeah.
Choosing me first. That's fine. Hospice is about choosing living life quality. A lot of people think that it is a dark cloud, like we used to think a long time ago. We have patients that graduate on and off. And a lot of times they do better with our team, our disciplines that come in, and we regulate not only pain, we're experts at pain, but we're also experts at the depression piece, the anxiety, the spiritual awareness and help and guidance, emotionally, mentally. And our company was built on the idea that we not only support our patients, but we support the families just as much. So by educating our families, loving on our families and our patients, it's a win-win, because that anxiety is pulled back a bit and everyone knows what's coming next. We celebrate the birth of a baby with such joy and anticipation. And we feel at Guardian Angel Hospice that it is just as important as going into the journey of, if you have a religious background, you're going into a different life. And so we do respect everybody and where they're at spiritually, of course. We like to celebrate and put together a care plan so that the patient feels as best they can in all ways, so we can have those celebrations. We can have those birthdays and anniversaries, and sometimes our patients can go on vacation, and our nurses and our staff will prepare them for those wonderful memories and times to be made. Usually our patients will stop, aggressive treatment like chemotherapy, most of the doctor's appointments and things like that. And really the focus turns on to just the quality of their life along with their families.
Anybody want to add in on this?
I will.
Okay.
So a term that my administrator used one day, just kind of talking to us about the approach, the way to view hospice. So the term I like using is holistic. It's a holistic approach to end of life care. And, like Cheryl was saying, it's so that way patients aren't spending their end of life in a hospital hooked up to monitors on IVs, that it's not fun being a patient in the hospital. It's very miserable. So holistically, hospice treats the symptoms so that way the patients can be comfortable, like you said, Jim. And but the term holistic is, I love that term about hospice. It's a holistic approach to end of life.
That's very true, Amanda. And I'm so glad that you said that, because I heard you mention about your aromatherapist. We also have a certified aromatherapist, which allows us to be able to use not just the morphine, as Jim mentioned. I know that so many people, when they talk about hospice and end of life, they'll say, well, they started the morphine, so it'll just be days. Well, that's not truly not the case for everyone. Morphine does so many wonderful things to treat so many symptoms that people have during the end of life process and during their journey. It's not just taking morphine and passing away a day later. It is about using our nursing staff, using our spiritual staff, using our social workers, our medical directors, our aides to be able to care plan together and meet the needs of that patient, and allowing the patient and family to be the driver of that need. I know that many of them have spoke about, it's really up to the patient. Hospice doesn't just come in and take over. Hospice comes in and walks alongside you.
Mhm.
Hospice comes in and guides you. This is what you may be seeing next. Call us if there is a change in condition. Call us, and if there is a question that you may have. Hospice is about being able to support them 24 hours a day, 7 days a week. It's not about being there 24/7. It's about supporting them. And if they need a visit, going out and being able to guide them, help them. Yes, triage over the phone, but yes, go out and make that visit to be able to be one-on-one with the family, train them, teach them so that they feel confident in what they're doing to be able to care for their loved one. Because hospice, death in itself, there's so much fear that is associated with it. But when you bring hospice on board, there's so much peace and guidance and comfort that can be added to the process, especially when you have somebody who's who's been in and out of many situations as a nurse, as an aide. But this is the first time any family member has had to take care of their mom or their dad or their son or their aunt, sister, whoever. This is the first time ever for that situation with that person. And every situation is different. So hospice is really individual. And so I like to tell people, as Amanda said, it's holistic, it is comfort, and it is individual. There are no two situations that will ever be alike. It's very individual.
And I'd like to piggyback on what you were saying. Hospice is a choice, and it is up to the patient and it is up to the family what they want to do. And I think that the stigma around hospice is that it's giving up. It's like, oh, once we've decided to go on hospice, we've given up. We don't want to seek treatment anymore, or we've accepted a terminal diagnosis. And that is hard for people. It is a milestone. But it is something that can be comforting. It is something that can be, like you said, supportive. And I know for our residents and for our patients, a lot of the time, this is the first time in their whole life that they've experienced this level of support. So yes, while they are at the end of their life, it can be a beautiful time. It's hospice is 6 months, or less, or give or take, depending on if you get back on it or not, but traditionally about 6 months or less to live. And I think, it's all of our jobs on this call and in the community to go out and hopefully get people earlier in that journey so they can experience that comfort and that relief and that peace earlier in that journey, so that, like Lynn said, it's not, oh, we started the morphine drip and the next day, mom or dad passed away. It's giving some control back to the situation earlier in the situation, so that people can have these meaningful life experiences with their family, so that the family can take that family role and not be that caregiver 24/7. You can be the daughter again, you can be the son again, you can be the grandkid again. Because you have people in your corner supporting you that you can call, that can come in and make sure that all the medical oversight is taken care of and you don't have all that pressure on you. So I think it's really a gift, that at the end of life, yes, I know that's difficult to kind of accept that that's where you are sometimes. And that's why we have, chaplains and spiritual coordinators and mental health professionals involved, because there are going to be a lot of emotions associated. But it's a support team, and it's something that, once you've just accepted it, it can be quite peaceful, it can be quite comforting, and it can be the opportunity to make some really meaningful memories, have some really meaningful conversations, and do some really meaningful things in those final days of life. Just because you're at the end of your life, that doesn't mean you're done. It doesn't mean you're just laying in bed and that's that. It means, you can still cultivate these beautiful moments. And like I said, for our residents, sometimes they're like, wow, this is the nicest I've ever had. Because our patient population in particular, might be homeless or might not have family at all. They don't have anybody in their corner. And that's when, our organization and then partnering with, hospice organizations like those on the call here, we can come in and be like, you don't have to do this by yourself. You don't have to do this alone. And we appreciate you and we give you that dignity back and we give you that comfort back. And so it's catching people earlier in the process so they have the ability to experience that relief earlier on.
Beautifully put.
And like you mentioned, Madison, using it earlier on. I think the thing we hear the absolute most, I wish I would have called you sooner. I had no idea that hospice does this, did this, can help with this, support this, give me this, all of these things, between the DME and the medications and the visits and, all these pieces. I wish we would have called you sooner, not just for the support, but, for the DME, for the medications, for the pain control, the comfort, the comfort, being able to make a memory and go somewhere. There's so many people say, I really wish, I had no idea that hospice did this. I really wish I would have called sooner.
I've got a question on this. This sounds so expensive though. All these things coming in here. Maybe I won't call because I'm afraid that I can't afford it. Is that what can you answer that one for me?
Yeah, hospice is a Medicare Part A benefit. So you're already paying into it. Hospice is paid for Medicare Part A, Medicaid, most private insurances. And I mean, I can speak, I'll speak for myself, but I think that some organizations are like this. We don't turn anyone away because of their inability to pay. We use a sliding fee scale and work with them and do their income to debt ratio to be able to come up with an amount that they can afford to use hospice services within their home. So no, it's not expensive to the patient or to the families. We do use as much, try to get into network with as many insurance companies as possible. A lot of times, if you just call the insurance company, that if you're in that area, they'll use you and allow you to be in network for that individual if they can. So just reach out and see if you're not sure if they take your insurance, just check. We do take VA patients as well. So, there are a lot of ways that you can have hospice provided for you. And if our organization is not right for you, check with Amanda or Madison, because, not every hospice is the perfect fit for every patient.
Right.
Shop around and not shop, but interview, be able to ask questions, be able to make sure it's the right fit for you. The organization that you're choosing is the right fit.
And if like you said, Medicare or what have you, it's pretty much you're done. And all these new services and new providers and new stuff is there for you. So again, I think about my own family. I'm like, that would have been nice to have known. So anyway,
most of our families are so shocked by that. I had a gentleman that I spoke to this week, and he said, again, what is the cost? And I said, in their situation, there is no cost. And I said, I know, because when my mom was on service, I knew nothing about hospice. And I asked the nurse several times, nothing good is for free, right? It always has some sort of cost. It's too good to be true. But it's such an earned benefit and such a beautiful thing to have. And I'd also like to piggyback and say that, the sooner we get our patients and families on board, we get to know them, they get to know us. We kind of become a surrogate family to them. And that time getting to know them And building that trust is just so important.
So what is the trigger point that hospice is available to someone?
What do you mean by that?
Well, okay, my father was, basically decided he wasn't going to do chemo, and so from that moment further, he was not doing anything necessarily to protect, to cure. Is that the trigger point, or is it when you slide to a certain level? What's the trigger point that it's okay to call hospice and bring them into your family?
I would say, there's a lot of, like hospice is individualized, so every case is going to be different. For your dad, it would have been, hey, okay, I'm done with chemo. I'm tired of how this makes me feel. That would have been a great point to start for him. But say you have somebody like with Alzheimer's dementia, how do you really know when it's that time?
Yeah.
So there's a lot of different factors that weigh in. And a lot of those factors are going to be changes in their condition. So whether it's frequent falls, lots of trips to the hospitals, weight loss, change in diet, are they having now trouble swallowing? Just indicators like that. So for like Brighton, me personally, when I'm out educating referral sources and things like that, or families, I tell people, even if you think maybe someone may not qualify for hospice, but you've called me in and you're just curious as to what the benefit is, obviously something has happened that's triggered you to call me. So what changes have happened? And a lot of times it is simple as that. It's a fall, every week for the last couple of months, and mom's been in and out of the hospital multiple times, and now she's really not eating, and we're starting to notice weight loss. And especially again, going back to that like Alzheimer's dementia diagnosis or any type of dementia, a lot of times those patients, when they start getting to that point, they don't have the ability to always speak for themselves and explain, hey, I'm just not feeling like myself, I really don't have much of an appetite. So those are some things that can help identify that maybe it's that time for hospice. And then at that point, of course, once a family decides if they're interested in having a referral made to a hospice company, then I know for Brighton, we are able to review a referral and determine if they're going to be appropriate for services or not based on all of those recent changes.
And like Amanda said, there is dementia, there is cancer. And I know that a lot of people historically have always felt, oh, it's just for cancer. Hospice is really just for cancer. And that's just not how it works. It is, end stage heart disease, it's end stage pulmonary disease. It is end stage renal disease. You have so many different diagnoses. And a lot of people will say, well, my doctor didn't say that I was terminal, or I don't have a terminal diagnosis. Well, you have all of these layers of different comorbidities and different diagnoses that are on top of each other that do actually build a picture of what a patient looks like that needs hospice services. And so, a lot of, you do hear a lot of, well, they didn't say that I was dying. Well, all of these on top of each other, that can be a 6 months or less. A lot of times it is longer than 6 months or less. Ideally, if we get someone on, and as someone alluded to before, people tend to improve a little bit once hospice comes on board because they have something to look forward to. They have somebody, as Amanda said, somebody coming in to see them frequently, checking on them, reporting back to their physician, reporting to their families. People are more engaged, and so they do tend to feel better, perk up a little bit. And that's when there's a hospice success. And as Cheryl said, people can come off of hospice and go back on. But you do have a lot of different diagnoses that people don't always associate with, oh, I didn't know I could be on hospice for that. So just asking the questions, and as Amanda said, in and out of the hospital, just asking the question, would hospice be appropriate for me right now? Is that something that, would benefit me and my family? Not being afraid to ask, because not all physicians bring it up. So not being afraid to say, I need extra services. I'm not interested in therapy, but what can help me? What are the services that can help me?
Lynn's right about that. I mean, a lot of people would never imagine if they could refer themselves to hospice, or their families could refer them to hospice. We usually think it's got to come from a doctor. And so just educating out there, and gosh, there's so many things that I used to believe that are so not true. And it's different now. So Jim, I'm really happy that you, and honored that you had us on today, because I think working through some of those old school way of thinking about hospice, it's very important to kind of up to date everybody.
Well, that's a good point. Because I often, when I'm trying to tell this to people, I'm always out there. I can't tell you how many times I'm having hospice conversations with people going, it's not what you think. I never really thought that was going to be part of my life doing that, but that is what I do now. In a lot of things.
Thankful for
I mean,
that.
the same thing with, like, you don't have to be poor to get Medicaid waiver. There's things that I got a lot of soapboxes I get on now. But what I think people have these perceptions and these understandings that they think they are, but a lot of times when I talk about hospice, they go, well, it must have changed, and it didn't used to be that way. Is that true? Or has it always been that way and no one's ever known? That there's all these, there's more to it than that last few days. I mean, Lynn, you've been doing it for 20 years, so I think you'd be okay.
Yeah, I mean, there are changes. I mean, we get changes every year.
Right.
I can't say that there are not changes, and what it used to be. It has evolved for sure. And it has become bigger. It has become more well known. We are educating more about what it is and what it is not. And I think there's just always been so many misconceptions of how hospice works, that yes, it has evolved, and there have been changes. And like I said, there are changes every year. But in the beginning, when hospice first started, yeah, it was just some volunteer nurses taking care of really, really sick people, and Medicare didn't pay for it at all.
Okay, so it has evolved tremendously, is what you're saying. Yes. Well, let me ask you a question. When because again, you've got, you got 6 months, and then people can graduate off of it and then come back onto it. And I have talked to people that said they've had patients that have been on it for multiple years, from this. That is not what people perceive to be the case, in the general public. I guess what I'm trying to go with this is, doctors aren't going to tell us that in most cases. Probably, if you've got a diagnosis, it may be a terminal diagnosis, it may be whatever. I think that and maybe I'm wrong. Are they, as a general rule, or doctors say, hey, this is an option you can do now, or are they waiting until it's that last 7 days before they bring it up in most cases? Because I think that someone told me in your industry that like 7 days is the norm, when it doesn't need to be. They're missing out on so much for not only the patient but the family.
Well, Jim, they've been trained to get patients better, right?
Yeah.
That's their schooling. And so, yes, there is I would say, on the smaller side, group that are advocates and really refer and believe and understand, but that's just a conversation they don't always want to have with their patients, who really, if they've had them for years, and their families, they are like family. And that's a hard conversation to have. So many of our physicians like the fact that we can come in and guide that conversation, and take the scary out of it.
And I'm thankful that you brought that up, Jim, because we have great physicians. I think we have one of the best medical industries here in Indiana. I am so grateful. I think that honestly, unfortunately, Jim, a lot of physicians have the conversation, bring it to the attention of the family, but it's not heard. It's not always accepted. It's not, physicians may bring it as this is the next step, or as you would go to a specialist for this, now your specialist is hospice. Now your next step in your care plan or in your progression is hospice. And when physicians approach that, their time is very limited with patients right now, because there's so much push from insurance companies and that sort of thing to move people quickly. As Cheryl said, we have the benefit of going in and having that conversation, going in and explaining everything, because that's our expertise. I mean, we're all experts here at what hospice is. And so allowing us to come in and have that conversation is just more comfortable for physicians. So for them to call us and say, hey, I've got a patient for you, or hey, can you go talk to this family? It's more comfortable for them to say that than, okay, let's sit down and talk about this. Sometimes, I'm not saying every physician is like that, but sometimes it is definitely just a benefit for them to say, okay, next step is for you to bring in some support, and that support would be hospice.
That's a good, the thing is, most doctors now get 6 minutes with a patient. So it's
Right.
It's hard to get all these conversations in there. So, that's
Right.
I think that
and
is the actual.
Fortunately or unfortunately, some patients think, well, if I choose hospice, I can't have my own physician. Well, that's not true.
Yeah.
You choose your physician. You have the right to choose what primary care physician you want. And your physician, if they choose to follow you, absolutely follow you. We follow up with them. We work with them, I can't even say that word now. Collaborating with them to give them exactly the picture that we are seeing in the home, to say, hey, they're not going to come to your office anymore, but here's a picture of what's going on.
And one of the things that that you brought that point up on, another thing, if they hire a hospice, so they bring on a hospice team and they sign, I am now in hospice. If they change their mind, they can change their mind. It's not like once you sign off, you're not like signing off forever that now I'm stuck, right? So there's, so you can kind of come in and out whenever you feel like it. Am I wrong on that, or?
Yeah. It's
I am
one
wrong?
signature. No, you're not wrong. You are right. It's one signature is all it is. And our goal is also to keep our patients out of the hospital. They can go to the hospital if need be, of course, and we have to sign some paperwork, when that's happening, because Medicare looks at it as you can't be in the hospital and on hospice at the same time. But yes, if someone changes their mind, they feel like they're doing better and they want to go for some measures like chemotherapy or some kind of therapy, absolutely, it's one signature, and then it doesn't take much to get them back on service when they're ready. We'll be here with open arms.
I've heard this, and I don't, I'll let you guys expound on it. So, because I know enough to be dangerous to say things and then just that's where I'm at. But I have heard, and this one, I've heard a lot of people are afraid to get onto hospice because they feel they can't get treatment if something else goes wrong or what have you. But if I'm on hospice for cancer, for instance, and then all of a sudden I have a heart issue and I want to go to the emergency room, I still can under hospice. Is that correct or not? No, yes, what? Yeah.
Well, it depends. It depends on the diagnosis of the patient.
Okay.
Yeah, it's all gonna, and Amanda was gonna speak up. I'm sorry.
Okay.
It depends on the diagnosis of the patient, the care plan of the patient, and what the comorbidities are of the patient. So I honestly can't say yes or no to that, because each is completely different.
But it doesn't shut you off from things that are not part of the diagnoses originally. If something comes from the outside, that's probably not a comorbidity. That's what I'm trying to figure out. That's what I've heard in the past, and I think that's could be beneficial to people to know. But that they're not shutting doors on everything is what it comes down to. So Okay, give an example. Going back to my dad, he was in a situation where all of a sudden he had a emergency. Had to do an emergency surgery, and they were telling us to say goodbye because it was bad. They opened him up and found out that the reason that all of his stuff was backing up is he had a congenital thing where he had a tendon that was cutting his intestines, and blocking it off. They clipped it, and he was perfectly fine.
Wow.
And the doctors were absolutely dumbfounded because it was just, one little
Wow.
snip, and he was fine for another 10 months, but anyway. Yeah. So that's what, that's one thing I was wanting to ask, were those things, how that stuff works. So, but what is, I think, am I mistaken? I've heard that it's like 7 days is the average, but when you get people to start listening to this, how, I mean, I know you guys are doing outreach. I understand that. And that's what we're trying to do here. But what I'd love to be able to do is figure out a way to get people to start the conversation. How do you, Cheryl, you're out trying to talk to people up front. I don't know when when they call you, if they're in that last part, or are you getting a chance to talk to people saying, hey, this is why you need to start at least opening the door and letting us look at the opportunity.
Educating in a lot of different ways out in the community. Our referral sources in like hospitals and doctors' offices are so important. I mean, I'm always very open to suggesting coffee out somewhere or meeting them at their homes, wherever someone would like to have a conversation about the gift of hospice. I also, no pressure. It's just information that you need to think about. And I always tell our patients and our families, it has to feel good here and it has to feel good here. And Lynn's exactly right. In order to decide that specific hospice organization is the right one for you. We believe in choice at Guardian Angel Hospice. We don't feel like we're the right hospice company for every patient and their families. We all bring a lot of different things to the board as far as what we can provide. And truly, it's an important decision. And it truly does have to feel, it match what you're thinking to your heart and how that feels.
I think culturally we can all do better. I think the United States, we don't honor death as much as other cultures do in other parts of the world. I mean, it's one of those things where if someone passes away, a lot of people are very uncomfortable even having a conversation with those, kind of left behind. They don't know how to approach it. Do I bring it up? And so I think part of the strategy that we're using here at Morning Light is to try and talk to people when they're not necessarily in a reactive mode, like trying to solve a problem, trying to, solve a crisis. How do we have these conversations with people on the day-to-day, just out in the community, hosting events and sharing what hospice is about in a lighthearted way, almost in a way where people aren't, they're not emotionally reacting, their defenses aren't up. I think unfortunately, just the precedent of the stigma of hospice and, how it's been done traditionally. We get people in those last 7 days, or we get people in those last few months. And then at that point, it's more of a difficult conversation to navigate. Whereas if they're armed with the information ahead of time, like I know, for example, we've been going out to like Butler University and lifespan development classes and talking to college students. I mean, they're kind of years away from ever needing hospice, hopefully for their parents, but maybe their grandparents need it. And so helping them, understand, in a way where they probably won't need it for a while. But here's the information up front, and here's the information, and then you can draw back on this information, hopefully when the time comes for your loved one or for your spouse or someone that you know. And so, just having these conversations more off the cuff almost, and just anybody who will listen, teaching people about the gift of hospice, as Cheryl put it. Because I think, if you can get people when psychologically their emotions are a little more stabilized,
Right.
then they're more receptive to hearing that conversation. Like you said, Lynn, the doctors might be having the conversations, but they're not being heard because it's in a stage of the process now where it's like, oh my gosh, I can't believe this is happening.
Right.
if that makes sense. Hopefully that makes sense.
I think
It's
it
not-
does. I think, go ahead.
It's
No,
not
I thought
easy
I
to
was-
do.
I thought I
We're
stepped on
trying.
somebody. I'm sorry.
So go for it.
It is, one of the things that, of course, that's what I'm out there doing all the time. Like I said, I'm constantly talking about hospice. I always find it amazing because to me, it was such a revelation to know that it exists the way it does. It just was like a total paradigm shift for me. So that's kind of why I've been telling people about it. It's like, because like you were talking to butler students, they may not need it, but you don't know who they're going to run into at work, or that may be needing it. So the more people we can have that they don't have to be experts, but they have to know there's more to it. If they can get to that stage.
It's an option. Yeah, it's an option. It's a tool that they can call on, at some point. And it's a reference point, just planting the seeds. As much as we can plant those seeds that we're here, you never know when they're going to be, when they're going to sprout and be needed. But hopefully those seeds of information can be better utilized in the community. And like you said, Lynn, I think it has changed a lot. I think that, the conversations are being had a lot more. It's an industry that's growing. We are at a tipping point, with boomers starting to age. I mean, families are going to need this information. This isn't something that Indiana as a whole can ignore. There's going to be more people who need care than there are caregivers. And so how do we arm these caregivers so that we're not all burning out and broken, and as a society trying to figure out how we support our seniors, when there's a limited resource of caregivers. So arming them with information earlier on, we have to do that right now. It's really important.
I also would like to mention that it's important to have a team of people that good referral sources, because sometimes a family doesn't have a lot of family support, or they're working full time. And we get to know our referral sources very well. So non-medical home care, or also called senior sitter service, might be something that needs, we're looking at the total plan when we come out, and we're hoping that it's not during the crisis situation where it's at the very end. Rather than, let's take a deep breath. Let's come up with some great referral sources that we know are very ethical. Let's sit here with you until we get this figured out. It's going to be okay. And it's very important to tell the caregiver and the patient that you're doing a great job. You're doing what you're supposed to be doing. I think just knowing that, and I was told that when I was taking care of my mother and my siblings, you're right where you're supposed to be. And you're doing a fantastic job. And now we're here to support you along the way. Lynn, I'm sorry I cut you off.
No, I was just I'm glad that you mentioned that, because there are so many resources that, and Jim, this is why you do this, is because there's so many resources people don't know about. People don't even know that they're available. They don't know that they qualify for them already. And with hospice, I do feel like, as you said, Jim, those 7-day span of being on services, that's just not enough.
Right.
It's not enough for the confidence to be built from the family to the care, to the care that the hospice is bringing. If you can get in earlier, they start to trust. That trust is built of, hey, did you say your pain was a 5? It really looks like it could be a 10. Are you comfortable with that? Well, I didn't want to say anything because I didn't want my family to be upset. So as the nurse, as the team coming in, you're building that rapport. And 7 days, it's just not enough. It's not enough to build that continued trust. You are in crisis mode sometimes. But as Cheryl said, really building the resources for that family of, hey, you've got to work, or hey, your FMLA isn't going to kick in until, so long afterwards, or you can't get it till Monday, allowing us to help you find really good resources to help you, to walk alongside you. That's, has Madison's, wonderful home that people get to go to. All of those are places that they don't know about yet. And so being able to bring that when they're not in crisis mode, and when you're just in care mode, when you're just in education mode, is a lot easier.
Yeah, and I was going to say, families that are in the crisis situation are not thinking clearly anyway. So I've been there too. You know, you're just trying to get through today. You know, so I don't, you know, and it's just hard to.
Survival.
Pardon?
I was gonna say it's survival. It's
Yeah,
survival.
exactly.
Oh, certainly.
The next 5 minutes at a time.
Hmm.
Yeah, and then when
You
you're
get
talking,
people
if you're in the
before they
hospital,
kick
you're
in.
getting totally different stories every 15 minutes. So you're like, okay, I don't even know where I'm at. But anyway, so and that's what we're talking about right now is why Life's Co-Pilot exists, because being the only sibling that stayed in state to have to take care of family members, okay, that became frustrating to me, how to get this information. Then when I got into the senior world and started meeting all these people, I'm going, wait a minute, why did somebody tell me? You know, and then there was a news article or news story that was being promoted pretty heavily. It was not a local story, but it was salacious, so the local places played it. It was an elderly couple that committed suicide because they were overwhelmed with like medical bills and what have you. And I was like, this is not necessary. It is, we do not lack services. We don't lack providers. We don't lack resources. We lack knowledge they exist and how to access them. And so that's really what birthed Life's Co-Pilot, to get you guys to be able to talk to them. So they're not getting this information from their barber's uncle.
Right.
Right.
Exactly.
So they hear it from people that are in the trenches that do the thing. So I want to thank you. This is the one thing that I hate about these is they don't last long enough. But anyway, so we're already at an hour. So I want to do a real quick screen share to tell you what's coming up real quick. In Life's Co-Pilot, by the way, you can always come here and get resources. There's blogs, this video will be in the video library by tomorrow. You go to events, and that, this was today's. We have one also going on this evening that one of our members is promoting on here. And then on the 16th, another one of our members has an event coming up. And then on June 28th, when I first started doing these, I was doing panel discussions in senior communities, and I just had, today we have people from competitive companies on here. I love that. Everybody plays nice and it works well. We're talking about the topics. Used to be I would have one from each, from each industry, just to show people the sphere. We haven't done one of those in like 2 years, so we're doing one of those again. I'm very excited about it. Here, there's a whole bunch of services out here. One on how to serve the seniors coming up. So I just wanted to show you, and you can always go into Life's Co-Pilot, look at events and see what's out there for people. So, and we're always there, and you can click on it, and there's a co-pilots that are available to direct you. And I can direct you to these wonderful ladies here if you need services there as well. So anybody have anything you want to talk about before we call it a day?
I would like to say that, yes, it's true that we're competitors in some ways, but I feel like it's important to get to know our other hospice companies in the area, because there's some times where we can't serve a certain area, but they can, and vice versa. So it's really nice to be able to help each other out, and knowing that we're doing the things for the right reasons out there when, we can't serve a certain area, or provide something that's covered where another company might be able to.
Very good. Anybody else have something you want to say?
I just want to say thank you to everyone on this call for what you do. It's a pleasure partnering with you all, serving the community in this way. Thank you, Jim, for giving hospice a platform. This is a conversation that needs to be had, and a lot of people aren't having it. So thank you for being somebody who's, promoting us and just helping the community understand what's available to them. I really appreciate you doing this.
Well, thank you.
Absolutely.
Thanks for coming.
Thank you.
Thank you.
Thanks, guys.
Thank you.
I will see you all later. Thank you so much. Great panel today.
Thanks, Jim.
All
See
right.
everyone.
Bye-bye.
Bye.